Yes?
I have a question about a CyberKnife. Is that similar to?
So, CyberKnife is a modality that is a robotic treatment machine, can give very focal radiation and minimal dose to surrounding tissue. Tomotherapy can do similar things to CyberKnife, and Gamma Knife can do similar things to CyberKnife. I believe, are you going to speak about CyberKnife at all or not? A little bit? Some of that will be addressed a little bit when Dr. Sim speaks about some of the very focal radiations, because CyberKnife is very focal radiation. But I believe, like in almost any area of medicine, there are competing modalities that are actually somewhat similar, although there may be some small differences. I think CyberKnife is a good technology in certain situations. I think certain technologies are better than CyberKnife in other situations. And really that applies to the realm of what we call radiosurgery, which Dr. Sim will be focusing on a little bit more.
Okay, thank you.
Any other questions?
What
Yes.
makes a brain tumor lesion different than a, say, MS lesion?
Well, multiple sclerosis is not a tumor, so it's not a neoplastic process, so it's not abnormal cells that are growing. And I'm certainly not an expert on MS, and that falls more in the realm of a neurologist. Multiple sclerosis is a disease of the nerves, and the nerves are not functioning properly. But radiation is not used in the treatment of multiple sclerosis, and really that falls in the realm of neurology in terms of medications to help the nerves function better. But that's an inherent abnormality in the nerves themselves, but not abnormal cell growth or a neoplastic process, which is what cancers and brain tumors are.
Okay, thank you.
Yes.
How often, I'm just asking about statistics, how often do you see patients with Lyme disease? Well, I'm one of them, but I have other issues.
Right, so I don't see any patients with Lyme. I mean, I do have some patients who have Lyme's disease, but I don't see them because of the Lyme's disease.
No, I know, because I have lesions.
Right. Yeah, I would say it's a small percentage of patients. My assumption is less than 5% of my patients have Lyme's disease. That's just a number I'm pulling off the top of my head.
But my case is more complicated. I have 3 different types of cancer in my body. That monitoring, they're not changing, some was removed, some shrinking, some is monitoring. So I'm more complicated, complex.
Right.
Might be disability of lesions because of metastatic, or just lesions because of Lyme.
Right.
A little bit more complicated.
Right, so that becomes a complex issue to differentiate what a lesion looks like on scan. You know, Lyme's disease, unfortunately, is an infectious disease typically transmitted by a tick bite. It is not an issue that we deal with in radiation. I mean, we don't treat Lyme's disease with any form of radiation, but that's where it becomes critical, going back to the issues of having that comprehensive team approach, is you certainly want to have a neuroradiologist that can really try to attempt to interpret what lesions look like on a scan to help us differentiate and make sure we're dealing with a malignant process or a cancerous process versus an infectious process. But that also brings up the point that it's very important often to sometimes do a biopsy, and that if a patient has no history of any cancer and has something in the brain, that doesn't always mean it's cancer or a tumor. It could be an infection. And there sometimes brings out the importance of biopsy and having a pathologist who can say, wait a minute, this isn't a cancer, it's an infectious process, which means, from my perspective, it helps me let a patient know that you don't need me. You need to see an infectious disease doctor or a neurologist, and they have to help figure out what the best treatment is. Any other questions? Yes.
When I was first diagnosed, the thought was I had an oligodendroglioma. Later on, a year or so later, it was considered anaplastic astrocytoma. Does that happen? Did it change?
Well, so oligodendrogliomas and astrocytomas technically start from 2 different cells within the brain. They're both primary brain tumors. when we look at astrocytomas by themselves, even someone who has a low-grade astrocytoma can undergo what we call transformation, where the cancer cells or the abnormal cells become more aggressive and transform to a more aggressive or a higher grade lesion. So they can become an anaplastic lesion or a GBM. Technically, an oligodendroglioma cannot switch to become an astrocytoma. However, what we also see is many fusion tumors. So tumors that actually have components of both, even to start. And it is possible that perhaps one component was a very small percentage of the total component, so they didn't really see that on the pathology. When we deal with pathology, although pathology is obviously very important and helpful, it's not a perfect science, and particularly if someone does only a needle biopsy, the pathologist is dealing with a very small percentage of the total picture. So if you were to sample just a very small area of a large area, what the pathologist sees may not correspond to what's going on a global scale. So there is some inherent inaccuracy in our procedures, although we do better than we used to and we continuously improve what we can do. So it's possible that perhaps there was a component of both even to start with, but perhaps a biopsy only sampled one area or something like that.